today we have Dr. Lori Michener presenting research updates. We are very fortunate to have an international expert in the area of shoulder pathology and rehabilitation on our faculty. Dr. Lori Michener joined our division 7 years ago. She is a professor and clinical scholar within the division. She is also the director of the COOR lab, and that is the Clinical Biomechanics, Orthopedic, and Sports Outcome Research Laboratory. Lori is a highly accomplished researcher. She has received numerous awards for her research related to the shoulder. More recently, she received the Marion Williams Award for research from the APTA, which is one of the highest research awards given from our professional organization, and also recently received the Founders Award from the American Society of Shoulder and Elbow Society for clinical research mentoring. And it is our honor to have Lori provide an overview of her research program for us today.
Thanks, Chris, for that. Welcome. Today, excited that I get an opportunity to talk about what we do in the COOR lab. Come on, there we go. In the COOR lab, one of the, I think it skipped over, I apologize. There we go. The mission is to optimize treatment for patients with rotator cuff related shoulder pain. And our second mission is improving performance and reducing injuries in overhead athletes. How do we do that? We look to identify neuromuscular and even venturing into the brain that I'll talk a bit about, biomarkers to target to develop effective interventions, and then perform clinical trials to assess the effectiveness or the efficacy of the treatments that we have identified. So, rotator cuff tendon disorders. It's the most common shoulder problem, and it can range anywhere from tendinopathy to tears in the tendon. And we predominantly look at tendinopathy in our most current work. Most recently, we've looked at understanding who responds to resisted exercise. As you can see in the graph on the right, we look at people over the course of their care and even after they leave our care. And so along the bottom is the baseline 1 month and 6 months that we followed patients after they've received intervention that lasted anywhere from 4 to 6 weeks. And along the y-axis is the patient-reported outcome with respect to their shoulder pain and disability. And what you clearly see is there's 3 groups in this patient cohort. We see patients who seem to respond pretty early, the dark black line, and they seem to stay well then when we query them at 6 months later. Then we see the other 2 groups that kind of look like they overlap. They respond as well to this resisted intervention, but they don't get as well and have as good of outcome as the folks in the early responder group. Then you see, as we query them at 6 months later, we end up seeing a division in these people, in this group. The delayed people who seem to continue to get a little bit better, but never quite down at that same mark of the early responders. And then the unrecovered group, they actually can get worse or stay the same, but they really end up having recurrent or chronic symptoms. What we're interested in, as you can imagine, understanding why these early responders are early responders, and then what really is the reasoning why people aren't responding, what is unique about those 2 other groups. We look at this tendinopathy in a couple different ways. We use ultrasound to look at tendon properties, and we found that both alterations in both mechanical and material properties within the tendon. We also look at neuromuscular factors, understanding why people may have deficits in their muscle that then is ineffective or reduced effectiveness in loading the tendon for remodeling. And so we found altered neuromuscular factors in predominantly the muscle's capacity and control. More recently, we've been also venturing into the brain and understanding how the brain dysfunction may, in both the sensory and motor regions, how that may be impacting both how people are processing pain coming from the shoulder, and also how that impacts then muscle output with respect to being able to produce muscle activity. In the other areas I alluded to earlier, is we also look at overhead athletes. And more particular, we've been recently looking at understanding why pitchers in particular have a high incidence of ulnar collateral ligament injuries. Those injuries are in the medial aspect of the elbow. And over time, as you can see on the graph on the right, these medial elbow injuries, in particular UCL injuries, are on the rise. These are the number of UCL reconstructions in 2018 versus 2012, and you can see this increase. And this is even more dramatic when you start to see the elbow injuries in Little League players as well. A lot of people initially started thinking it was really related to an increase in ball velocity. The faster you pitch, the more torque you get at your elbow, hence why you are having these elbow injuries. But it's a bit more complex than that. Recently, we've started looking at metrics of elbow injuries, in particular UCL and these baseball pitchers, using elbow varus torque, a surrogate for injury risk, because that torque is the predominant mechanism by which these UCL injuries occur. And we look at this torque ball velocity profile and then trying to understand what physical factors that are modifiable may mediate that torque velocity relationship. Just some interesting data that we have been looking at, or just finished analyzing and have out for review, that if you look at the torque velocity relationship, velocity along the x-axis, torque along the y-axis, that it looks like there's really not that great of a relationship, and the r-squared 17%. But if we start clustering these people, it becomes a different story. There's clearly is a group of pitchers, and it seems to be about 50%, that seem to have a really high relationship. The person I don't want to be, that the faster I pitch, the higher my torque keeps going. So they aren't able to mediate this ball velocity when they're pitching well. Versus then there's another group of pitchers that really have very low relationship, if almost none, that they can keep pitching faster and faster and have not really a demonstrable or a big increase in their torque in their elbow. What we venture to try to find out is what physical factors really mediate this relationship. And I'll leave you with that question, and we'll be providing that answer hopefully within the next 6 months. Thanks for your kind attention. If you're like the shoulder or interested in athletic injury risk, join us, come chat with us in the COOR lab. Thank you.